So my case is, it's a 73-year-old male patient with bilateral osteoarthritis knee. He has pain since last 2 years. He was more symptomatic on the left side. And on examination, there is a flexion deformity of 15 degree on the left side with valgus 30 degree on the left and 15 degree on the right side. Range of motion till 100 degree. And this is the long leg X-ray of the patient, 33 degree varus on left and 18 degree valgus on the right side. So this is the CT scan of the patient. I don't have the lateral views. So there is a big posterolateral defect. And
so let's stop right there. Who on the panel is getting a CT scan? Harish, let's start with you. Are you getting a CT scan preoperatively?
We need to have a good quality AP and lateral, and if there is, if you find on that some significant bone defect, maybe CT scan, but good AP and lateral and a scanogram to see how does the hip and overall bone to
yeah, so you saw this case. Are you getting a CT scan?
I wouldn't. I mean, it wouldn't make a big difference to me.
That's my, okay, good. Arun, would you get a CT scan?
Yes, because we are doing some research studies, but not otherwise.
Fair enough, okay.
Routinely, no. I do good, X-ray with lower femur and upper tibia and as well as skyline view and as well as the scanogram.
Okay.
No.
No.
All right, so no one's using a robot, no one's getting a CT scan for the robot, someone's getting it for research, but why did you get the CT scan?
because I do image-based robotics, so that's why I got the CT scan.
Okay, there's your answer, good. Okay, we don't need to see it though. Let's keep going.
So this is the pre-op clinical picture of the patient with a varus thrust. He was more symptomatic on the left and he wanted to get operated on the left side only.
Okay, so I mean, I guess that's the bigger question. He's got bilateral flexion contractures, bilateral deformities. Is this the case that you would consider doing bilaterals on if the patient were willing, Harish?
I think I should prefer unilateral. We need to see also the other medical factors in the patient, the age, the hemoglobin and the albumin level and medical comorbidities like hypertension, diabetes, etc. But one at a time should be good enough.
You're not concerned about the bilateral flexion contractures and correcting one limb?
The left is little more deformed, the right is not that deformed, it is about 15 degree, which is not too bad.
Okay, fair enough. Arun, would you want to do bilaterals or?
I do bilaterals very frequently, provided the cardiac condition is good.
Right. Dr. Mohanty?
Yes, grade 1 and grade 2 patients without any cardiac comorbidities, I would go ahead with a bilateral total knee replacement.
I do bilateral simultaneous knees, but I would say in this case it's a question of understanding the patient's health and whether there's a real reason forcing you. The modest flexion contractures wouldn't push me too hard.
Right.
Yeah, I do bilateral as well, but just in straightforward cases, not in complex cases.
Right, so I mean, I think, there's no question there are indications for bilaterals. They have to be healthy patients. So all things being equal, though, there are situations where patients have significant enough deformities that you should consider bilaterals in those particular cases. When the flexion contracture is large enough bilaterally that it would, it might affect their outcome. All right, keep going.
So I planned for a robotic-assisted functional alignment with a medial subvastus approach. I do all my knees with medial subvastus. So this is my CT planning. So I planned a 3 degree of valgus from the mechanical axis for the distal femur cut. Initial plan was 2 degree internal rotation to the transepicondylar axis and the overall limb alignment of 3 degree valgus with a femur size of F and tibia size of 6. So this is the examination under anesthesia. The valgus deformity was partially correctable.
So, but you had a mechanical access, a zero-newt mechanical access. That's what you're aiming for.
No, I aim for 3 degree valgus.
Well, go back to that picture. Go back 2 slides.
Okay. One more.
Yeah, that looks like it's zero mechanical.
Sir, at the lower down, the mechanical axis is 3 degree valgus.
Okay.
Because the distal femur cut is in 3 degree valgus. And the tibia in neutral.
All right. So let's keep going.
So this is the exposure with a medial subvastus after the exposure. So this is the gap check. When I give a valgus stress, the gap is 13 on the medial side and 1 on the lateral side. And with a varus stress, I can balance the knee in extension, that is 10-10 both on median and lateral side, with a limb alignment of 3 degree valgus. In flexion, when I give a valgus stress, the gap is 9 on the medial side and 0 on the lateral side. And when I give a valgus stress, it's a varus stress, I can balance the knee, that is 9-9 both on medial and lateral side, with a final 3 degree of valgus. So I balanced my knee both in flexion and extension with 1 mm more on the extension because of the flexion deformity and overall alignment of 3 degree. So this is the cuts and this is the final gap check after the bone cuts, and the alignment is 2 degree of valgus. And this is the final picture, and the patellar tracking is good. And this is my post-op X-ray.
So you're suggesting you did all of your balancing through bony cuts?
Yes, sir.
You didn't do any soft tissue lateral?
I have not done any soft tissue release in this case.
Okay. Now, do you think you could have done the same thing if the deformity was not partially correctable?
No, if it's a fixed deformity, then I need to release it partially.
All right, so why did you use a constrained insert there, the audience is asking?
Sorry, sir?
Is that a constrained insert?
Yes. I use a constrained poly because the medial side was lax. MCL was attenuated. That's why I used a constrained poly.
So wait, you used a computer and a robot, and now your medial side was lax?
I want to be safe, on the safer side. That's why I use a constrained poly.
Well, so let me throw something at you here.
That was pretty interesting, right? Because you just said that you didn't need to balance the knee, but then you ended up using a constrained implant because the knee wasn't balanced.
Right.
It's a little bit interesting.
It is, and I want to correct something in the audience here. Is the medial side lax, or as I suggested, your lateral side is tight, right? You need to open up your lateral. It was partially correctable, but it wasn't totally correctable. You need to open up your lateral side so you can get a bigger spacer in, a bigger insert in to balance your medial side. Your medial side isn't lax, but your lateral side is tight, right? Anyone disagree with that?
No, I mean, we have all seen that the medial collateral was insufficient and the lateral was tight. And just to correct it with bony cuts, in my hands, it's impossible.
Yeah, I would agree with that statement. And your X-ray would suggest it's difficult too. And you didn't resurface the patella.
No, sir.
And you didn't do a fascicectomy.
Sorry?
You didn't remove the,
No, I removed the osteophytes.
okay.
Yes.
So is that your routine?
Yes. I don't do patella.
And do you do electrocautery around the patella?
Yes, I do that.
Okay. I think there's some good evidence that you should get rid of the lateral facet, though, if you're going to not resurface the patella. Does anybody here, who resurfaces the patella? Raise your hand on the panel. And the rest are selective resurfacers? Or never? Who never resurfaces the patella?
Never, I'm never.
Never. So if Thorsten and Ashok are never, okay. And then you're selective? Always. Okay. You have anything else to add?
Yes, this is my final alignment X-ray. It's around 3 degree of valgus that I was aiming for.
Amar, may I?
Sure.
This guy has a significant plano valgus, in other words, a flat foot.
Yes.
You're leaving him in 2 or 3 degrees of valgus, and then you're putting in a constrained implant with a post. I think if he's a younger guy, you're going to risk post wear. I think the key is really to balance that knee. I think all the drama about the robotics and the angle and the planning is all very good, but at the end of the day, you need to have a balanced knee joint. You cannot rely on a block of plastic to stabilize a valgus knee. I think that's a fundamental principle.
Yeah, I mean, I agree with that. I think this knee is at some risk for late instability or post-wear. But so far he's doing good, and we should applaud you for your efforts.
Thank you,
Do
sir.
you have anything else to add?
No, that's all.
Amar, the discussion should be that in case of in presence of plano valgus pit, what is the approach? What should be the approach?
Is your question, should the foot be done first, or?
Yeah.
So who would want
To address the foot, or you just forget about the foot, or you leave the, alignment to neutral rather than giving it valgus?
So let's go down the panel. Who is getting the foot fixed first? Rajesh?
Only if the foot is very asymptomatic, I would get a consult from a colleague, foot and ankle surgeon. If an asymptomatic planovalgus, I wouldn't go after the foot.
All right, is anybody getting the foot done first?
No, and generally speaking, the foot and ankle guys don't want to do it first. They want you to straighten out the leg, and then if there's still problems, they'll fix up the foot. I think what Merrill Ritter's data showed us, though, is that if you straighten out the leg and you've got a bad planovalgus foot, that can still screw up the knee. So if it's really bad, you may have to go fix it secondarily. But what I would say is you don't want to leave a knee like this in valgus. I think that was Arun's point, and I agree with that, because that is going to cause a problem, the double valgus.
Can I just make one point?
Sure.
I think with the previous discussion on robotic surgery, I think the message is going that you do robotic surgery and you can get anything corrected without balancing the soft tissue. You don't need to do balance. And this is exactly the case which somebody may do, I mean, you do robotic and then you don't balance and then you constrain design because you think it is medial lax. So that message should not go that robotic doesn't mean you don't need to do balancing. You still need to do it if it is required.
I 100% agree, and I think it's we've always talked about this being a soft tissue operation, right? It still is, as I meant. Not only do you have to balance, but you also have to, respect the soft tissues and make an appropriate incision and and close the wounds properly. All those things are factors that can have major impacts on the outcomes of the knee replacement. But yes, I agree. If I'm doing a valgus knee, the last thing I want to do is leave that knee in any residual valgus. Does anybody have would defer on that?
Just one other point, Amar. Everything said is absolutely correct. Using a constrained option without some sort of even a mini stem is another recipe for that getting loose. So in addition to everything else, not leaving it in valgus, getting it to a neutral alignment, doing a soft tissue release, and I couldn't agree more. Use of robotics is not a sort of a facet where you forget the soft tissues. And no matter how much you say that you don't do soft tissue releases, I have a question to ask. How do you subluxate the tibia in front of the femur without a soft tissue release? How do you do that? I mean, at the end of the day, if you have to pull the tibia in front of the femur, there has got to be some amount of soft tissues. How do you remove posterior osteophytes on the medial side or lateral side without some soft tissue? So if you say you minimize the soft tissue releases, yes, I get that, I accept that. But to say I do no soft tissue releases, that's a hard one.
One important point to add that in case of valgus knee with flexion deformity, I prefer to use a PS knee rather than a shear knee. Of course, with a balanced knee, because that allows you to, correct the flexion deformity by sacrificing the cruciate, as well as that given option of placement of your components little bit. You have some play in the placement of the components.
Yeah, I mean, that whole concept for me has changed now that I do a lot of CR knees where I sacrifice the cruciate ligament, and so because of these ultra-congruent designs and everything else. So in general, if I do a valgus knee, as I published on it, I'll use a PS knee. If I know I'm going to cut the PCL, I will probably start off with a PS knee. But I think nowadays there's plenty of cruciate retained designs where you can use a cruciate retained design, but you probably are sacrificing the posterior cruciate. Right? Anyone disagree with that statement? All right, do you have any other points you want to make?
No, thank you.
Okay, thank you very much.